Very much for that warm welcome. I'm going to pour some water. So that was a really warm welcome, and so you all know that I don't do all of that by myself, right? I have a wonderful team of people at every hospital that I've worked who actually do all the work. And I sleep well at night because they don't sleep and they take care of our patients. So wherever I've been, it's always about the team and about bringing people together to do the important work, which is to take care of the patient. So they take care of the patient and I take care of the staff. So the nurses and all of the staff, that's my job, is to advocate for them and to take good care of them, make sure they have what they need to do their job. Okay, there we are. So can you all hear me? I think you can. Okay, so I'm going to talk to you a little bit about evidence-based practice and what it's meant to me in my role and how we use this to enhance the work of our patients at Exxon that I've worked. So thank you so much for having me today. So DNP PhD. And when I was thinking about coming and what I was going to talk about, whenever I talk to nurses, and I have lots of nurses who come and talk to me, I have students, undergraduate, graduate, doctoral students. I had a PhD student with me a number of years ago. Like, so you want to be with me? Why do you want to be with me? And she had a particular focus on nursing leadership, and I didn't have a doctorate at that time with me so she could learn more about leading. So I thought that was fascinating. And so when I'm thinking about talking to people about their degree, what I always say is, what do you like to do? What do you hope to be doing in the future? Because based on what you want to do in the future is really going to help me give you guidance around potentially what's the next degree you should get. And so depending on and sometimes people are like, well, I haven't thought about that. I'm like, well, you really have to think about what you want to do. So if you really like to take care of patients, then let's talk about how we keep you closer to the patients. If you want to get into research and you want to produce new evidence, then let's talk about what that looks like too. And you can actually have the best of both worlds. That's the one great thing about being a nurse. You can do so many things. So what do people aspire to? That's a question I ask often. And I didn't always aspire to be a chief nurse. I used to look at the person who was the vice president, and usually I was afraid of them first, and then I thought that they couldn't be human. I'm like, they must be particularly different people because I don't know who could do that job. So I didn't always want to do the job, but the reason to want to be a chief nurse is you have a bigger ability to influence and to make a difference and advocate for nurses and patients across the entire system. So the higher the position, the greater your ability to impact or to lead, and that's really the attraction. So DNP schools have grown dramatically over the last 6 years and really have blossomed everywhere. So there's 264 DNP programs in the country. That's a lot, and many of them have started in the last couple of years. So if you think about, there was 170 students in 2006, and now there are over 18,000 DNP students in the country. That's a wow, right? So we have to figure out, so what's the attraction? Why is that? What does that mean? Well, the good news is that it's going to increase the percentage of nurses who have a doctorate, which is very much aligned with the IOM Future of Nursing report, because we need more people that have a doctorate, a PhD, we need more educators, and we also want to make sure we level the playing field with our other clinicians. PhD programs, 134 programs in the country, 1,000 students. That has grown over 3%, but it's not growing at the same rate, and we're going to talk about why. So really, it's looking at ways to learn and what it means to you as a person, the school that meets your needs. So how do you choose? It depends really about what you want to do and where do you want to be. And I had a lot, I was first looking, said to me, Barbara, you have to get a PhD. I had colleagues, they were like, Barbara, it's the wrong decision for you. And I'm like, well, what do I do? I've spent my entire career in taking care of patients, taking care of nurses, advocating for better patient care and outcomes. And so I want to take the evidence that my buddies in academia and research have created, and I want to use it, I want to put it to work. So whenever our staff wants to make changes, and we have a very shared decision-making model, when our staff wants to make a clinical change, the first thing we say is, where's the evidence? What's in the evidence? What's in the literature? And some of them say, Barbara, there isn't any. I'm like, okay. Something, or there's lots of literature, but we're a little bit behind. And this is what we want to do, and this is why. So it's always about the evidence. And sometimes when I say at some of our meetings, I'll say, well, what are the other hospitals doing? Some of my mainline health colleagues, they'll say, well, Lankenau's doing this and Paoli's doing this. I'm like, no, outside of mainline health. Like, I know what we're doing, but what's Jefferson doing? What's Penn doing? What are hospitals in Boston doing, right? So some of it is geographical, community standard, but much of it is in the evidence. So how do we take the evidence and get it closer to the patients? So you heard that it can take about 17 years on average to get it from the evidence, proven, to the patient. Well, that sounds like a really long time. And I don't think that's the best way to take care of patients. So when I took care of orthopedic patients way back in the 80s, early 80s, I know some of you weren't born then. So when I did that, patients stayed in the hospital for 12 days. We turned them with an abductor pillow. They weren't allowed to get out of bed. They had big giant incisions. And now we're doing an anterior approach with an incision this big, and they go home the next day. Boy, things have changed, right? So we have to change with them, and that's why it's so important that you read journals. And we're going to talk about that. So again, what do you aspire to do? What's the role you have? What kinds of things do you want to do? Is it research? Is it formal research? Is it quality improvement? And both are good, and both are helpful. So if we look a little bit deeper into the differences and how, so what was important to me is I wanted my, as a terminal degree, I don't really like that terminology, but that's what it's called, the terminal degree. I wanted to make sure that it was meaningful to the work that I was doing. So I nurse I could be. And around me, I thought I have a lot of years to work. I think to school. My husband said, I thought you were done when you got the MBA. I'm like, well, I thought I was done too, but I don't think so. So, you know, if you have 10 years more to work, you probably need the next degree. So some of you are like, uh-oh, I have a lot of degrees to get, right? So it's really important that you think learning. And again, it goes back to how do we lead other people? How do we impact patients every day? And what I say to our staff is, you know, at the bedside, you should ask your patient, what's the one thing I can do for you today? I'm going to be here. My name's Barbara. I'm going to be your nurse for the next 12 hours. What I can do for you that will make a difference? And do that. Because to that patient, that could be so important. And it might be, it's our 65th anniversary, and I'd really like to have a card for my wife. So you could make that happen, right? You could make a handwritten card. You could go to the gift shop and get a card. Like, that could be something very, very meaningful, kind of unrelated to their clinical care. But if they're worrying all day long that they should have bought that card a week ago and brought it with them to the hospital, but of course they didn't know they were coming, right? So those kinds of things. Or if a patient says, I'd like to walk to the bathroom. I haven't gotten out of bed and I'd like to walk to the bathroom. You make that happen, patient's exhausted, they want to get back in bed, but they're like, I did it. I've accomplished it. It's my goal. So that's important that we connect with the patient and meet them where they are. And so when I think about evidence and how we put evidence into practice, evidence also takes a look at what's important to the patient. So what's the patient's story? And where should we try to engage the patient in their state of wellness to return them to the greatest state of wellness that we can? These are the sort of the list of things that you would look at for degrees. And important, I think, is lifelong learning. So hopefully, many of you are reading lots of journals now. And for those of you who aren't students and you've graduated, maybe you've graduated from Villanova, I hope you're reading at least one journal, either electronically or the old-fashioned way by paper. But I hope you're reading at least one journal in your specialty every single month, because it's so important that you know what's in there. What I like to do, I have a lot of journals I like, but I can't possibly spend enough time reading all these journals. So I scan the table of contents. Because if you look at the table of contents of any journal, it gives you a sense of what's important and what's out there. So if I look at diabetic journal, or if I look at Journal of Nursing Administration, or that's probably one I actually read cover to cover. But if I look at another gerontological nursing, if I look at research nursing, right? If I look at any of the journals, there's lots of them. If I look at the table of contents, I get a really good understanding about what's important in that field. So in your field, look at the table of contents. You don't have time probably to read every article either. So here's my tip. You read the abstract, and then you decide whether you want to read the whole article. And sometimes you read the overview and the end, so the conclusions, right? And you can get a good sense, and you still feel like you're well informed, but maybe you don't need that journal to do your work tomorrow or next week. So that would be one of the things that I would say. Always read a journal. So if you're working with other colleagues, they should be reading at least one journal. And when someone gives me an article and says, Barbara, you should read this, I always read it. You know why? Because they've already read it and they've already vetted that it's really good. And so I can invest my time. And that's how we help each other. If everybody, all of the nurses across the entire system read one journal and they all identified what was the best article, that would be very helpful to all of us. So actually part of our council structure, we have a journal article at every meeting. And we take the time, and different people participate every time it's assigned. So once in a year, they might have to present an article, and they get a little nervous about it. But they try to pick an article that's connected to the work that we're doing. My two councils happen to be leadership and professional development. And then they present the article. They tell us what was important. They sometimes say, you know, this is really connected to this other goal we're trying to work on. And then we all read it, and we learn. And so you can do it in a very short time. I think we take about 10 minutes in a meeting to do that out of a 2-hour meeting, which is very helpful. So lifelong learning, big opportunity for us. And also when you do this, when you get students, whenever I get a student, and I have students almost every semester, and sometimes I have multiple students, so I always have a list of projects. I have things that they can help me with. So recently I was interested in what we're doing across the system on perinatal bereavement, and could we do it better? And so I asked my student, so find out what other hospitals do. What's in the literature? Does perinatal bereavement connect to palliative care? Do you have any articles on that? So she did a whole assessment. She got me articles. She did a PowerPoint, and she summarized what we thought we could do to have a more formalized program across mainline health. That's really important to me. And she did a bunch of work, which she needed to do to be successful in her clinical with me. But I also got something meaningful out of it, because I always have a list. When I talk to staff or nurses and they're like, Barbara, I have to do this project, I don't know what to do, I'm like, let me get my list. Because I always have a list of stuff that people could do. And that's how you contribute in a meaningful way, and that's how I think you utilize your students. So I'm going to talk to you about what I did. MP program, I'm going to talk you through my study, because I think it's really helpful to see how it relates to the work that I do. So this is all about working together as a collaborating, embracing students, engaging them, students everywhere. And some of my students say, you know, my other friends, they get excused, they don't get to go to everything. I pretty much let my students come to everything, even senior executive council where my boss is sitting there, all the presidents are sitting there, they get to come because we're a learning organization and we want you to really experience it. And they're sort of used to it. I'm like, I have a student, they're like, of course you do. Because I have, but it's really, really good that we show people what it looks like in action, and then they can say, I learned that, but I've never actually seen that in a meeting, but I just did. My study. So I took a look at nurse managers and their impact, not that affected quality engagement. This is important because you would know that staff nurses leave organizations because of the nurse manager. Now my nurse managers, some of them are here and they're like, we hate when she says that, but it's true. So when you go to work, it's about the people, it's not about the bricks and mortar, it's really about the people. But likely, if you don't feel like your nurse manager's fair, consistent, kind, follows up, follows through, and has a little bit of fun, you're probably maybe not thrilled to be working with that nurse manager. So really important the nurse manager's engaged, they're a good communicator, they're visible, all those things. So what I studied the literature, you know, did a literature search, read over 100 articles, got down to my group of articles I wanted to use, and I identified leader-member exchange, which I'm going to explain to you. And I wanted to understand if leader-member exchange theory if I had a manager that had a good score, sensitive indicators, which are falls, CLAPSes, CAUTIs, retention, staff engagement, and then of course, did the percentage of BSN nurses on that nursing unit have any impact? And when I looked at leader-member exchange, it has been studied mostly outside of nursing. It's only been studied in nursing in the last 7 years. And the theory was really about communicating with everyone and making sure that you don't go back to the same people and ask the same people to do more work. Because what do? People do good work. We reward them by giving them more work, right? But there's a lot of other capable people. And when you continually go back to the same people, you miss the opportunity to give someone else a job and the opportunity to do something good. And I know when I reach out to a nurse and say, I'd like you to do this for me, they're like, you want me to do it? I don't know, Barbara. I'm like, yeah, no, I think you can do this. And then they come back and they bring me what they did. It's so good. I give them positive feedback and they're like, thank you for the opportunity. I didn't think I could do this, but now I have a renewed sense of what I can do, what I can accomplish. And that's what we do in our shared decision-making model. So this theory was very helpful, and Dr. Laschinger was the person who studied it the most. So I really looked at what she did. So here's leader-member exchange survey. It's basically short, very short, 7 questions. You might say, well, some of the questions sound a little strange, but you can't really change the tool because then it doesn't become a reliable tool anymore. So I took the questions just as they were. So how well does your leader understand your job problems and needs? How would you characterize your working relationship with your leader? So this is the survey we sent out. And I had great participation, and I had to be careful because I am the chief nurse of the system, and I didn't want people to feel unduly pressured. But I said, I'm going to school, I'm a lifelong learner, I need your help. If you guys don't participate in my study, then I won't be successful, so you have to help me. So first I had to talk to the nurse managers and make sure, because I was going to have information about them, right? And they're like, Barbara, are you going to tell the vice presidents? I'm like, no, total secrecy. They'll only know if you tell them. So I did the survey, and we looked at how we could measure it across the entire system. And when it had been done before, leader-member exchange had been done before, they looked at these things. So they looked at organizational identification, satisfaction, structural empowerment, knowledge transfer, but nobody took it a step further to look at quality. So I looked at that. I did a huge understanding or synthesis of the literature. Definitely the nurse manager, vital, key, important, and very important to engagement of the staff. So I wanted to understand that across mainline health, across all 5 hospitals. So it's the relationship, it's the people, right? It's how I connect with you. And I described earlier that I used to be afraid of the person who was the vice president. Well, I was actually afraid of the person who was the nurse director, because when she walked on the unit, we all scattered like cats because she wasn't very friendly. She seemed a little mean. I'm sure she wasn't mean, but our impression was she was mean. And so as nurse leaders, we have to make sure that we are welcoming and engaging, and that people kind of forget what our title is, right? So my title's a little intimidating, but I'm a nurse. First, I'm a nurse. And so I want to connect with my staff. And do you have the tools to do your job? Is there somebody that's particularly important that helps do your job well that I should recognize? Do you have any questions? Do you have any rumors you want to ask me? I always ask them that. They always laugh. I'm like, do you have any rumors? Anything you want me to know, or anything you want to ask me? And that usually breaks the ice. And then they're like, oh, okay, I can sort of ask her a question. Well, Barbara, I heard this. And then, they're connected to me. And then the next time they see me, not really an issue to ask me any question. But we have to do that. We have to remember that our position brings power, which brings a scary part to us, right? I'm sure you have it with the faculty, although I'm sure none of the faculty are scary, right? None. Okay, so what we did was we took a look at this assessment, and we compared it to the nurse-sensitive indicators and the BSN rate, et cetera. So what we want to do is understand, how do we use the data with the nurse leaders? And how do we make sure that it's meaningful to the nurse leaders? So first I had the nurse leaders take it, I just had them do a self-assessment so that they could see what it was themselves. And we gave that back to them with their own data from their unit. So across 5 hospitals, and we were looking for, were there ways that we could use this information to add to their professional development? So would it tell us things that would help us? And the other thing about professional development, what we historically had done is say, well, what needs do you have? And we would do a needs assessment on the leaders and the staff. But if you go to the literature, There's already things out there that have been studied and proven that help people to be better in their roles, whether it's clinically or as a leader. And so I said to Professional Development and Leadership Council, can't we go to the literature as opposed to saying what needs do you have? And so that's what we did for our professional development at the system level. So now the Leadership Council is responsible for providing full day or half day leadership every year, and they've done an outstanding job. And actually last year they provided leadership development for all leaders across the entire system, and they had over 400 people participate in their 2 days. They had 2 separate days that it could be available, and we even included some physicians, and they came. And one physician, he couldn't come for a full day, so he came the morning of the first day and the afternoon of the second day, and they were so impressed that they got a physician leader to come and participate, and we got really great feedback. So that's how we use the literature to define the education instead of saying what needs do you have. It's just a different spin for us. So I did a descriptive cross-sectional design convenient sample. So I have 3,000 nurses, so I could reach out to them, tell them what I was doing, and ask them. They were very responsive. Yeah. It only took a couple emails, and but they were pretty responsive. And I actually sent it out to all staff, but in my particular study, I only looked at the nurses. But I do have all the data for all the unlicensed staff as well. But so I had a 35% response rate, which was great. The response rate by hospital, pretty good. Overall, 35%. And then you can see the highest was 44 down to 24. Still not respectable. Excuse me. Demographics of the group. Surprised that there's 95% female, right? Sorry to all the men in the room. But still, it's 62% were full-time, and then you can see the age was pretty much split, and 1% years of experience. And that's pretty impressive. We're definitely engaging that staff. Had 2 units, so we took that into consideration, and 7 managers had less than 2 years, so we looked at them separately first to make sure they weren't included. Leader member, and the scoring is at the bottom, so very low is 7 to 14, up to very high. And overall, you can see that 3 of the hospitals scored in the high range and 2 in the moderate range, but overall moderate. So and together, which moderate you could say is, if it's a 5-point scale, if you take the 4s and the 5s, it's pretty. Bell curve looked. So a couple people on the low side and a couple. Learned about the data was there was no relationship to the percentage of BSN nurses to just a piece of information that I was curious about. So no relationship to nurse retention, nurse sensitive indicators. There was one relationship, which I'll talk about, but otherwise a big connection. Now, one of the things that we talked about was for about 7 years now, to begin with, done at another hospital that didn't have, you wouldn't see the impact. We weren't sure. Catheter associated UTIs, we did see a relationship to the LMX score of the nurse manager. So that's kind of fascinating. And we did a regression analysis, and then we did the scatter engagement. So we do a so a very long data every engagement, and these are that we look at. So there's an overall category, and then there's questions that we look at. So the way this looks, professional growth was highly correlated to the nurse manager's leader member exchange score. So really surprising, but very good information for us to have. Teamwork was also positively correlated to the leader member exchange score. If we highlight the data and we talk about who we are, the definite relationship for engagement were in these categories. So that's a lot of categories. Now, interestingly, in the overall category, it wasn't statistically significant. And we ran that more than once because I was like, well, wait a minute, how can we have this many categories, but overall we didn't have a statistically significant number, but we just didn't, but we did run it again. But these are important things: communication, feedback, effectiveness, mission and values. So do people understand the connection at 2 o'clock in the morning on Saturday to the work that they're doing, to our mission, to caring for the community, to being committed to education and lifelong learning and quality and safety and creating excellence enough so that when they come to work, they're like, yep, I'm all about this. I'm all about culture of safety. I'm going to raise a concern. I feel like my manager's going to have my back. So some of the strengths and limitations of this particular study was, it's pretty big. So I did 58 nurse managers, 5 hospitals, 85 clinical units, and over 900 nurses that I was able to use their data. So from that, but some of the limitations were that it's in our particular region. So is geography an issue? It could be. Supply and demand. When I did this, it was 20. And so even things have changed since then, so it's 20. We did not have any trouble recruiting. We had more staff applying than we had positions, so we didn't have a lot of turnover. And then also some of the surveys done every year in the fall, and I actually did this in February and March. And so, you know, typically you might another thing just to keep in mind. And then self-reporting, the design of the studies are all self-reporting, and that is sometimes a little bit more just something you have to pay attention to. So when I think about practice and the work, the way that I promote it is I don't do anything without it. I am best friends with the librarian. So I know we can do it ourselves, and I know even at Vanderbilt I could go online from my home, and I could get great access to the library, and it was fabulous. But it's also pretty easy when I phone a friend or I send an email to my friend Joan Wolf at the library at Bryn Mawr. Got to meet her right away. I'm like, Joan, I'm Barbara, I'm the new chief nurse. I'm going to school. And she was like, oh, can I help you? I'm like, yes, please. And she still helps me. I literally will ask her, I would say every other week, I send her a request about literature, evidence. And I'm like, Joan, what can you find on fill in the blank? And you know, usually within 24 hours, she sends me back what she found, which is wonderful. She'll send me websites, she'll send me articles, I mean, really helpful information. And that's the kinds of friends you need, right? So I still am asking her 2 years later for articles. And then I use those articles with my team. So when I'm presenting things or I have ideas or I'm going to the council, I bring the evidence with me and say, well, this is the article I was reading, or based on our conversation last month, I asked for these articles, this is what I found. And so clearly there are expectations at our organization that evidence is really important. And how you use the evidence, you have to make it meaningful. So what I mean, it's not enough that we say to staff, so you want to change a policy, where's the evidence? You want to update policies, where's the updated evidence? You want to create something new, where's the evidence? Because sometimes we bring evidence to people and they're like, yeah, it's not broke, don't fix it. Or we like the way we do it. Yeah, that's a small study, you know, I mean, they have a lot of reasons. So not only do we have to welcome it, we have to expect it, create the environment so that evidence gets incorporated into the work that we do. And with 5 hospitals, I'm sure you could understand, they don't always agree on what to do. Or if someone says, well, we've been doing it this way for 7 years, and you know, we've been doing it, we do it a different way here, but we don't have all the same resources, or they have a lot of reasons why they do it differently. But if you're a patient with chest pain and you come into our emergency department, I would say they should be taken care of very similarly. And if you're admitted in one of my hospitals, you should likely be admitted in all 4 of them, right? Would you agree? And if you're going to come deliver a baby at Mainline Health, we deliver 8,000 babies. If we're going to have you use CHG wash at one of our hospitals, you must use it at all 4. And that's kind of the standardization or system work that I get to do with the teams all the time. And it's really helpful because we do want the same experience. We do want people to have the same access. So palliative care is another example. So 3 years ago, if you came to Bryn Mawr or Paoli, I could provide you with palliative care. If you went to Lankenau or Riddle or Bryn Mawr Rehab, I couldn't give you palliative care because we didn't have it. And you know, that's a sad story. So we have to fix that. So we've now fixed it, and you can get palliative care across the entire system, including Bryn Mawr Rehab, because we have changed enough things, and we've created multidisciplinary teams, physicians, nurse practitioners, nurses, social workers, spiritual care providers, to make sure that wherever you enter our health system, we can meet you where you are with the palliative care or with whatever your needs are. We try to meet you where you are and get you the care that you're looking for. So that's the embracing the evidence, right? So, and you know, palliative care programs, just as an example, you can have physician-led palliative care programs, you can have nurse practitioner-led palliative care programs, but we wanted an interdisciplinary model. And at one campus, I had a physician-led group. At another campus, I had a nurse practitioner-led group. I said, great, let's take the best of both worlds and bring them together, which means we all have to play together, and we're not going to pick one over the other and say one's better. We're going to say, let's create what we can that will be the best experience, not only for the practitioners, but for our patients. And that's what we've created with palliative care. So when I think about PhDs and DMPs, it's really about our contribution and what we bring. And so what I bring to the table is advocacy and inclusion, collaboration, as well as setting the stage. So when I'm at the table with the senior leaders and we're talking about palliative care, and they say, well, Barbara, you know, why do we have to change our model? It's been working, and oh, we were the first in the system to have palliative care. Did you know that? I have to make the case, and based on national data and other palliative care programs, which have grown dramatically over the last 7 years, we know interdisciplinary palliative care is the best. So let me tell you what the outcomes are when you have palliative care. And we know that patients live longer with palliative care than they do sometimes with chemotherapy. That's the evidence, right? So it's bringing the evidence even to the senior level to make the conversation, to make sure people understand why it's so important. And you know, when I talk about embracing everyone, and when you think about a kaleidoscope, so we named this presentation actually quite a while ago, but to think about a kaleidoscope, if we all had a kaleidoscope and you all looked at it, wouldn't you see things differently? You might see sort of the little particles, or somebody might be drawn to a particular color. Maybe it's your favorite color. Please note that these are mainline colors. I did that on purpose. But you might be drawn, and then what happens with a kaleidoscope, you move it, right? Just ever so slightly, and you hand it to another person and they see something totally different, right? That's all good. So what I think is the most important message is to embrace everyone and to value the contribution that they bring. So for my colleagues who work in academia and who do research and participate with us, I love that. That's why I take students, and that's why I have so many students, and that's why my leaders have lots of students. We're all about students, and we want to help sort of grow people, and if they can learn from us, they can spend some time with us, we think that's very valuable. We have Dr. Tammy Kears part of our faculty at Mainline Health, so all of my nurses, literally all of them, she's very busy, all of them have access to her. Now she has a particular role with the Research Council, with the Research Fellowship, which we offer, and also with our nurse residency program, because they have to all do an evidence-based practice project in order to finish the nurse residency. So brand new nurses at a school, never done really a full evidence-based practice project. They do it as part of their residency. They present posters, and they meet with Tammy, and they do a really great job. Some of the best research that we're doing at Mainline Health is with our residents. They are impressive people, and they're changing the way we give care. I have one resident who went out and got a new piece of equipment to monitor breast flaps in a much more, less annoying way to the patient, but a much a higher level of monitoring for the breast flap. She worked with the vendor. She negotiated a tremendous reduction in the price, and her outcomes are pretty impressive. So we're going to change the whole way that we take care of breast flap patients because of the work that this resident did. That's impressive. She hasn't been a nurse for 2 years yet, right? So think about that. And I have a lot of those. So we have a lot of good things going on. So I think the paths that we choose, our experience, so you heard sort of my journey through nursing. I love being a nurse, and I always loved taking care of patients. And actually, I always had 2 jobs until I became a CNO. And then I couldn't figure out how to take care of ICU patients and be a nursing supervisor anymore. But I did do it for 7 years when I worked at Methodist in South Philly, because I love taking care of patients. So I really try to create an environment where the staff have the best environment to give and receive care, and that I advocate for them so that they want to continue to work for us because of our outcomes and because of the environment they get. But I think that all of us, whether, whatever school we went to, of course the best are here at Villanova. That's it, right? Absolutely. So whatever school we go to, whatever educational journey we take, we can bring something valuable to each other. And so I am particularly excited just to share sort of my thoughts about that, because I learn as much. So I have graduate students, and it's a little bit of a challenge. I have to prepare for them, and I have to spend some time with them, which takes time out of doing other work, but it's so important, and I learn from them. And I just told you I make them do my work, right? So that's what I get back for spending my time, and I really am invested in creating the leaders of the future. So that's really important. So when I think about lifelong learning and all the benefits, I mean, I completely loved going to school, and my doctorate was so exciting. So on Fridays, I know you'll find this hard to believe, but on Fridays, after I worked 4 12s and one, 8 or 10, I'd go home and I'd be like all excited, and I would say to my husband, I'm so excited that I can go upstairs and do schoolwork tomorrow. And he's like, you are not right. But I was really excited to have that time, and I did almost all of my school on the weekends. And I was really excited to have that time, and I had no trouble because it was so fulfilling. I learned so much. I was challenged. I was a little worried. My first paper, here I am running down the stairs with the laptop. I'm like, will you please read this? Will you just check it? He's like, Barbara. I'm like, I know, but I haven't written a paper in a long time, and just read it and give me your feedback. And luckily he was like, that didn't continue. I got better, and I didn't ask him to read all my papers. But I was worried, and people knew I was going to school. I'm like, what if I can't do it? The pressure. What if I can't do it? I'm the chief nurse of Mainline Health. What if I can't do it? And we all think that. So you've all been in a place, right, where you were like, I don't know. And then I had to take statistics. Oh my gosh. I was like, all right, I remember this. I've taken statistics at the college level. I can do this. But it was scary, right? You want to be successful. You want to do it well. And so I think that, no matter what position you hold in the organization, stay true to the patient and the purpose, and be connected to the people that you work with, because we all bring value. Whatever our experiences are, whatever our education, I can learn from every person, no matter what their education, and I do think that they bring great value. So it's been my privilege to be with you today, and I am happy to take a couple of questions, right? I think I heard that.
Is about bringing people in from other systems and how you get them acclimated as leaders. We've had, as
That's a good question. So one of the things we do is we make sure that the onboarding process is standardized and consistent hospital to hospital. So we actually just did some revision to that, and we went out, actually somebody did it as a Greenbelt project, part of lean development. They went out and talked to a group of newer nurse managers, some from within, some from other organizations, and said, so how did we do? How could we do better? They gave us a lot of feedback, and so our system director for education revamped all of the orientation and the checklists and shared that with all the people that would need that at the campus level, and now we have a standardized approach, and we're going to take it down to the assistant nurse manager, which we call the coordinator at Mainline Health. But I think the harder part of your question is, how do we make sure that when we bring people in from other organizations that they feel welcome and they're not met with, well, no, that's not how we do it here. No, that's not how we do it at Mainline Health. So I think that the shared decision making, the evidence, and setting the stage to say, you know, so just because we've done it that way for the last 7 years doesn't mean it's the right way. So it's always challenging, and I consistently do it, challenge the group to say, well, even though we're doing it, it's not broke, are we sure it's the right thing to do? So supporting them, it's hard to do. We have great longevity, which we value, but then we also, they don't have exposure to other things. So they're kind of used to the way that we've done it, or the mainline way. So thank you. Other questions? Okay. I don't know if she's gonna ask a question. Are you coming to ask a question? Thank you.
Thank you so much. I just think as a future graduate in a few months, how did you foster your natural leadership abilities to then position to your various management positions?
Very good question. So I think that it comes with time. First, I would say to you to be authentically present. So with your patients, be present with your patient and meet them where they are. That's really important. So taking care of patients, that's sort of our core work. And if I can connect with the patient and not have the patient feel that load of the other patients that are outside that I have to go tend to, then that's a good connection with the patient. But for leadership, it evolves. I still question whether or not I've communicated well or whether I could have done something different, even today. And I've been a nurse for 30 years. And, you know, I think you're always trying to improve your leadership. And so you ask people. So when I was a charge nurse back in the 80s, a nurse came, as I was in charge, I went in and told the nurses in critical care, I told her she was getting a patient from the operating room. We took patients directly. They didn't go to the PACU. And she came out and she said, Barbara, you know, you should hear what my patient just said. And I said, what did she say? And she said to tell you that you can capture more flies with sugar than you can with vinegar. And I looked at her and I was like, was I not nice when I asked you about this patient or told you about this patient? She's like, no. So I was in charge. I was a new charge nurse. I was sort of taking that role with the power. I'm like, I'm in charge. I'm going to tell you what to do. But I can tell you what to do and get the job done in a kind, respectful way. And I don't have to use my authority, right? So I think that's how you build leadership. So I remember exactly that day, that patient. I can tell you what room it was in the ICU. In that hospital. And then every time, every position I've learned, and when I've switched positions, one of the things that I do is I reflect about what do I want to bring with me and what do I not want to repeat. And that's a really important exercise. And I have had the fortune, I think good fortune, to have a number of different positions. And every time I've really been thoughtful about, so what do I want to do as a leader? And in my current role, I often say to the team, I've only been a chief nurse for a system for 3 years. So if you have recommendations or suggestions or ideas about how I can do it differently, or if you've been in another system and that chief nurse did things and you thought, wow, that was great, please tell me. And what did I do when I got the system job? Oh, I phoned a friend in the library and I said, could you get me all the articles on system chief nurses? And she did. So I think it's lifelong learning, right? So I literally still have that stack of articles on system chief nurses, and I read every single one of them because I wanted to understand what is it that I should do to be the best. And I think lifelong learning is really important. So now we're going to have a panel, right?